Hello, my name is Katie Snyder. This video resource is for the Respiratory 6920 course. My presentation will offer information on the King Airway. The objectives of this presentation are describing the King Airway, the pros and cons of the King Airway, discussing how it is inserted and removed from a patient's airway, and describing how to choose a proper size based on a patient's height only. I would like to briefly talk about the development of alternative airways. The laryngeal tube was developed in Germany and introduced to the European market in 1999. It was approved for use in the United States by the Food and Drug Administration in 2003. The design of the laryngeal tube has been modified several times since its creation. Each modification was made to improve its function. It was developed to help manage the difficult airway when bag mask ventilation and tracheal intubation are problematic or not possible to achieve. The design and use of the King Airway. It was created as an alternative to tracheal intubation. The King Airway is a supraglottic airway. This device creates a seal in the hypopharynx and distally in the esophagus. This effectively isolates the glottic opening and allows for positive pressure ventilation and provides some protection against aspiration. The airway features a shorter tube length, a curved shape, and has an anatomically shaped distal tip and cuff for easier and proper placement. It only takes a few seconds to insert. The marking on the tube allows the healthcare provider to know when the proper depth has been reached. This type of airway minimizes sore throats and airway trauma since it does not sit in the larynx. The product is latex-free to ensure it can be used with patients with latex allergies. The King Airway seals in the esophagus and oropharynx to provide positive pressure ventilation. A single inflation port is used to fill both balloons with ease. The King Airway is available in several sizes. Each size is color-coded at the tip. The device features a high-volume, low-pressure balloon system for less trauma and is designed to be placed in the esophagus every time. Here are some pros and cons of the King Airway. The pros are it is simple to use by healthcare providers. The majority are disposable, so there is no risk for cross-contamination. The reusable tubes can be autoclaved up to 50 cycles. The King Airway minimizes trauma to the airway. Each size is color-coded to easily choose the correct one. A pre-packaged kit can also be purchased, which contains all the necessary materials and instructions. For example, a kit would contain the tube, proper size syringe, lubricant, and instructions. Some of the cons of the King Airway include that it cannot be used on a responsive patient with an intact gag reflex or any known esophageal disease. It should not be used on patients who have ingested caustic substances. It is not proven to protect the patient's airway from effects of regurgitation and aspiration. Also, intubation of the trachea cannot be ruled out. This is a comparison of two commonly used King Airways, the King LTD and the King LTSD. They both seal in the esophagus and oropharynx to provide ventilation. They both have a single inflation port, are disposable, and latex-free. The King LTD was reported as the safest and most reliable supraglottic airway tool. The main difference with the King LTSD is the gastric access availability. This access to pass a gastric tube through a second channel of the airway and into the esophagus and stomach. You can suction with up to an 18 French suction catheter through the gastric access. These pictures show the specific parts and markings of the King LTD and King LTSD. They both are latex-free and single patient use. They have an orientation line. The depth markings are measured in centimeters. They have a single valve pilot balloon that inflates both the proximal and distal cuffs. They both have ventilation outlets to allow airflow to enter the trachea. The distal cuff in the King LTD completely blocks the esophagus. The distal cuff of the King LTSD blocks the esophagus, but there is a distal tip opening where gastric access is available. This table illustrates the different colors and sizes of the King Airway. It describes which size and color should be used based on the height of the patient and shows the cuff volume needed for each specific size. When choosing a tube size, height only matters in the decision. Weight, age, and gender are irrelevant. The size 2 is green and requires 25 to 35 milliliters of volume to inflate the cuff and used on patients 35 to 45 inches tall. The size 2.5 is orange and requires 30 to 40 milliliters of volume to inflate the cuff and used on patients 41 to 51 inches tall. The size 3 is yellow and requires 60 milliliters of volume to inflate the cuff and used on patients less than 61 inches tall. The size 4 is red and requires 80 milliliters of volume to inflate the cuff and is used on patients 61 to 71 inches tall. The size 5 is a purple tube and requires 90 milliliters of volume to inflate the cuff and is used on patients greater than 71 inches in height. This diagram shows the placement of the King LTD airway. As you can see, the depth markings are measured in centimeters. It refers to the distance from the vocal cords to the teeth when placed properly. The proximal cuff inflates at the base of the tongue. It isolates the laryngeal pharynx from the oropharynx and nasopharynx. The distal cuff inflates in the esophagus. It isolates the laryngeal pharynx from the esophagus. Gas flow passes through the ventilation outlets into the vocal cords to the trachea. The single inflation valve is located at the top of the tube. Both cuffs are inflated with that valve with ease. The insertion process for the King airway. To properly insert the King airway, first you must choose the correct size for your patient. The cuff should be tested for leaks by inflating it with the proper volume, then deflating it again after checking and before placement. Apply water-soluble lubricant to distal tip and posterior aspect of the tube. Pre-oxygenate the patient prior to placing the airway if possible. Position the patient's head. Insert and gently advance the tube until base of the connector is aligned with teeth or gums. Using the syringe provided, inflate the cuffs with the appropriate volume for that tube through the single inflation port. Attach a resuscitation bag. Bag the patient to assess ventilation. Simultaneously withdraw the airway until ventilation is easy and free-flowing. The depth markings on the tube give an indication of the distance in centimeters from vocal cords to the teeth when the tube is properly placed. Confirm proper position of the tube with auscultation, chest movement, and capnography if available. The cuff pressure can be checked with a cuff pressure gauge, or also known as a cuff manometer. Normal cuff pressure is 60 centimeters of water. The King airway should be secured with tape or other accepted means, such as a commercial tube holder, to avoid misplacement. The patient can be manually ventilated with a resuscitation bag or placed on a ventilator once the tube is secured. A flexible endotracheal introducer can be used to upgrade the airway to an endotracheal tube if or when needed. Removal process of the King airway. Once a King airway is in the correct position, it can be well tolerated until the return of protective reflexes. It is important that both cuffs are completely deflated before removal. Remove the appropriate amount of air from the cuffs based on the size and specific cuff volume of the tube. Removal of the tube should take place in an area where suction equipment and the ability for rapid intubation is available if needed. The mouth and area above the proximal cuff should be suctioned prior to removal of the tube to avoid aspiration. These are some points about airway management and resuscitation with the King airway. The American Heart Association calls for focused efforts on quality cardiopulmonary resuscitation. They are claiming less time off the chest is better. Using an airway device that reduces field intubation time but has similar performance to endotracheal intubation will improve patient care. Endotracheal intubation is a motor skill that requires practice. When there is limited intubation experience, another airway adjunct should be considered for a respiratory compromised patient. The King airway allows for quick airway management in the most challenging situations with minimal training. Many healthcare providers are often unfamiliar and hence uncomfortable with the King airways. Most tend to want to change the airway even if it's effective. Prior to removing the King airway, evaluate whether it is working. If it is working, do not mess with success. There have been reports of military cases where the airway device was left in for several days without complication. I have spoken to a paramedic who witnessed a patient brought into the emergency department with a King airway. The patient was placed on the ventilator with it, and later on that day the patient was flown to another facility with the same King airway in place. Follow-up reports on the patient stated the King airway remained the primary airway until the patient expired a couple days later due to other complications. In conclusion, the King airway offers a simple, easy, and effective alternative airway. It can be inserted with minimal amount of training. Each tube size is color-coded at the top for easy recognition. The King Airway was designed to minimize airway trauma while maximizing ventilation. The King Airway offers an alternative to tracheal intubation or bag mask ventilation when necessary. These are the references utilized for this project. That concludes my presentation. Thank you for your time. Have a good day.